Hello, everyone. Hi, everyone. My name is Jess. I'm the alumni coordinator here at the School of Nursing. Thank you guys for coming to our anesthesia panel today. We have some great alumni who have volunteered to provide their knowledge and their experience on the Nurse Anesthesia program. And then we also have two wonderful moderators today. We have Laurel Miner, who is a faculty member here at the University of Pittsburgh School of Nursing, and Bettina Dixon as well, who is also a faculty member. So kind of how everything's going to go today, we're going to have our moderators ask some questions of our panel, and then at the end there will be a Q&A available. So if you have any specific questions for our panel, then we'll hand you the mic so that you'll have a chance to ask those. And yeah, enjoy the panel today. And also thank you to John O'Donnell. He's our program director here at the School of Nursing. He helped us find these wonderful alumni and our moderators today. And yeah, it should be a great event. Afterwards, we'll have some snacks and food and drinks for you. And you can feel free to network and ask more questions if you want to talk to anyone specifically. So we'll get started and enjoy.
Thank you.
You're welcome.
Well, thanks everybody. Thanks for coming. It's nice to see all of you on this afternoon, evening. I'm Laurel. I'm a new faculty member here at the University of Pittsburgh School of Nurse Anesthesia. I'm also a practicing CRNA at Washington Hospital, so I work in the community setting, which is a little different from Bettina. She can tell you about her experiences. Oh, now? Yes, of course.
Can everybody hear me? We're doing the mic so that other people can listen and they're recording this. So any of your questions that you're asked, will be on recordings. You can listen to it someday. I'm Bettina. I'm one of the faculty here at the Nurse Anesthesia program. I've been teaching at the school since 1995. So I started when I was 10. I have experience at working at Montefiore and the Presbyterian Hospital across the street, a few other places. It's clinical, but full-time across the street, part-time here right now at the school. And we're here today to ask our panel some questions, and as Jess mentioned, for you to ask some questions too as we get through the end of this, so you can take some notes or whatever if you. And we can also give you some information. I'm a original certificate in nurse anesthesia, and I went back to school to get my master's so I could teach, and then I went back to get my DNP so I can continue to teach. So I've gone a long pathway. It's great now that we have a program that is straight to DNP. So, okay.
That's very exciting. So the first question that we want to ask our CRNA panelists is to tell us a little bit about your educational pathway and where you're working now. So, you want to start?
So, hi everyone, I'm Jacqueline. I don't know. She said she's not to.
Oh, okay.
Yeah, I think
Perfect.
those mics are going to pick up everything.
Perfect.
So I went to Pitt for my undergrad to get my BSN. I graduated in 2012. After getting my BSN, I started working at Children's Hospital Pittsburgh in their pediatric ICU, straight out of school. I worked there for about 2.5 years, and then I started anesthesia school. I graduated anesthesia school. It was master's only at that time. I graduated in December of 2016. And then in January of 2017, right after graduation, I started working as nurse anesthetist at Children's Hospital again, all about the kids. And I've been there ever since.
And I'm Holly. I'm originally from North Carolina, so I got my first degree in biology actually. Graduated in 2006 and started the very next day in nursing school at the University of North Carolina, Chapel Hill. Graduated in 2008, and then I worked at Duke for a couple of years in their neuro ICU. Then moved to Seattle, worked at Harborview Medical Center in their trauma ICU for a few years. And then came here, decided I wanted a break from ICU and worked in interventional radiology at Presby. And then I decided I did not like that, so I applied to this program. I got in. Jacqueline and I were actually classmates. And so we both graduated in 2016, and I currently work as a CRNA at Presby.
Hi everyone, my name's John. So my first degree, like Holly, is in biology from Penn State University. I took some time off, then went back for a secondary accelerated bachelor's here at the University of Pittsburgh and graduated in the summer of 2015. Initially took a job at Allegheny General on a cardiac step-down floor and worked there for about a year. and then I moved over to UPMC Shadyside. I still work there just casually right now since we're in school full time, but I've worked there since 2016, and I just started the program in January of this year.
My name is Shane. I got my BSN at Penn State. I graduated in 2012 from that program. I moved back to Erie, is where I'm from. Worked at St. Vincent Hospital there. I didn't get into the ICU right off the bat. I did a year of med-surg, then went to the medical surgical ICU there, worked for a couple of years. I started the program here in 2015 and graduated in December of 2017, and have been working at UPMC Presbyterian right across the street ever since.
Hi, I'm John. My educational experience is a little bit more convoluted. When I was in high school, I went to an EMT program and loved it, and I became an EMT and a paramedic, and very quickly realized that being a paramedic doesn't pay a whole lot. My expenses were a little bit higher than that would support. So I figured, well, what can I do? And the best thing was to go back to nursing school, because that's kind of like being a paramedic, right? But it's not. And I tried a number of different things in nursing. I graduated from CCAC with my associates, by the way. And I tried a number of things in nursing. Chronic hemodialysis, which is not like being a paramedic, and intensive care unit, which is still not being a paramedic, and finally the ER, which guess what? It isn't like being a paramedic. So at that point I decided to go back to school and get my bachelor's, not knowing what I wanted to do, but knowing I didn't want to waste all of the time I'd spent. And then during the Pitt bachelor's, you had to do a shadow experience, and I'm like, well, I'm working in the ER, I'll call those OR guys up and just check it out, and loved it. So I applied, I got in '99, I graduated in 2001 from Pitt, and I've been over at Presby ever since, loving the dysfunction over there. But I had another problem, that was how to pay for school. Since I was married and we had a house, no children yet, a couple of fur babies, but they don't cost much. So I joined the Army, Army Reserves, and they gave me some stipend and helped me out, and I was only going to put in a few years, whatever I needed to do to pay that back, because I graduated, and that was 20 years ago, and I'm still in, so.
Hi everyone, my name is Alex. I graduated from Pitt with my BSN in 2014. Right after that, I started working in the CTICU at Shadyside, where I worked for about 3.5 years. And then I got into Pitt's DMP anesthesia program, and I started this January. I'm actually classmates with John, and we also work together in the CTICU. So that's where I am right now.
So our panel's all been introduced. We'll jump down to going back to the CRNAs. We'd like you to give an example of what you love about being a CRNA, or give an example of a kind of case that you love, that you really enjoy and you get excited about whenever you're assigned that day. So, well, you want to start at this end and work our way backwards and change it up a bit, or?
Sure. You want to fight for it?
No. Rock, paper, scissors? No.
All right. So I work over at Presby. Again, for any of you that are familiar with the UPMC system, Presby, they get the sickest of the sick. Anybody that other hospitals can't deal with goes to Presby, and especially trauma patients. And that's the thing that after 19 years of practicing anesthesia, it still gets my blood up is a trauma case. I enjoy the complexity of trauma patients, especially the surgical complexity, not knowing what's going on, how are you going to fix it, all of the metabolic changes, the fluid, the volume resuscitation, how am I going to keep someone asleep and safe and comfortable, but yet keep them alive at the same time, because anesthesia does bad things to your blood pressure and your heart rate. So for me, trauma is still my favorite type of case. Sucks for the person that's actually having the trauma, but for the practitioners, it's pretty cool.
I don't have like one particular case to go off of, but I just like the variety of cases we're able to do in anesthesia. Everybody thinks it's just the typical surgery, we're behind the drapes, intubating and stuff like that, but we do so much more. We go over to Western Psych, we do ECTs, do GI lab, EP, cath lab. We go all around. Every day is different, and that kind of mixes it up. And it's not the same patients over and over again. You're getting sick patients that are provide different challenges every day. And those challenges just make the job very enjoyable sometimes. Sometimes it makes your life a little hard too.
Same, working at Presby, I love the organized chaos of it all. You just never know what you're going to get. And as these gentlemen have said, just everybody's so sick. You're doing a general case that you would think would be a straightforward appendectomy, and it's not. And you're constantly thinking, you're constantly being challenged. But my favorite part of the job is when you wake that patient up, if they're well enough to talk to you and tell you, hey, thank you, you know, like, I feel better, I don't have pain, or, you know, I appreciate what you've done for me. I had a gentleman yesterday who told me, you're a strong woman because you put me to sleep, so.
You go, Paul. So children's is a little bit of a different animal than adult anesthesia. We see, like Shane said, we do OR cases, but we see patients in a variety of places. You can't tell a 6-month-old or a toddler to lie still for 2 hours for their MRI scan. So we do anesthesia for a wide variety of things, and I think one of the things that drew me to children's is I loved bonding with my families while I was a bedside nurse. It was one of the saddest things when I left the bedside. I was concerned that anesthesia wouldn't give me that fulfillment of like bonding with my patient and my family, because they're only awake with you for such a short period of time. But because I can see them at their MRI scan, and we do a lot of chronic kids, I can see them for their follow-up EGD, or if they're getting a central line or a Mediport, or they're getting the Mediport removed, I can still bond with those families, and the parents will give you a hug and say, oh, I feel so good that I know my daughter's safe because you're with her. So that really was like one of the things that really pulled me to children's and why I continue to love my job there.
That's great. Thank you. So this question is for John Jones only. You mentioned you have, this is a special question, you mentioned you have a military background, so can you explain to us a little bit the difference of being a military CRNA versus a civilian CRNA?
Sure, nobody's shooting at you. No. So the military in military treatment facilities, so hospitals on Army bases and Air Force bases and whatnot, it's the same standards, same JCO regulations. You can walk in there and it just looks like a civilian hospital. There's no difference, except maybe you're taking care of more of a healthy population, because 18-year-old soldiers tend to be pretty healthy. Overseas is a little bit different. Overseas, you're in some very austere conditions, taking care of the worst trauma patients imaginable. There's nothing, you can work at Presby, and I've told people this 100 times, Presby gets some pretty bad traumas, absolutely, gunshot wounds, beatings, stabbings, whatever, but nothing compares to a blast wound. Everything's affected, and you're in the worst place imaginable, taking care of the sickest patients imaginable, and by the way, you can throw the emotion on top of it, that's probably a buddy that you may or may not be taking care of. So there's a big component of both you know, the emotional aspect of, okay, you're taking care of a soldier, the fact that there may be more than one of them, because let's face it, if it's a blast injury or trauma injury or you're shot, stabbed, whatever, downrange, there's probably more than just one guy coming at the same time. So you can have 2, 3, 4, 5, 6 at the same time. And if they're all as sick, who do you tell has to wait? Who do you evac? Who do you not? Anesthesia folks are an integral part of what's called mass casualty plan. We go out and we help triage. We help get those patients into the operating room. And then, especially in your more forward teams, your more isolated teams, there is no physician backup. You have your surgeon, you have your anesthesia provider. That's it. Whereas here, if I'm next door and something's going on, I call my doc, I say, I don't know what the hell's going on. Can you come in and give me a hand? There is no backup. And so you have to figure it out. Usually you have another anesthesia partner, another CRNA. There are times that you don't, and then so you really are it, and so you have to be very comfortable with your skills.
There's a second part to this question as well, just for you, because you're enrolled in our MSN to DNP, and so can you tell us a little bit about some of the things that you're learning and how they apply to your clinical practice?
I think the biggest thing I learned is not to go back to school when you're 45 years old. No, just teasing. I think the DNP is giving me that total strategic overview. You know, as clinicians, we're focused on our patients. If we're in a managerial role or a head nurse role or a CRNA director, we're focused on just our department. But anything outside the building, who cares? Or outside maybe the system. I don't care what's going on in Allegheny. I'm at UPMC. But that DNP program is giving me that whole strategic focus, healthcare policy, national policy. You know, I used to sit there and say, boy, that was stupid. Why did the federal government decide to do that? Now, I can say, boy, that was stupid, but at least I know why they did it. So it gives you that overall policy view, and it makes me feel more comfortable that maybe 5, 6 years when I get my DNP, I can take a more of a policy role or a managerial role or even an educator role.
Thank you.
All right. For Alex and for John, if you maybe want to talk a little bit about what motivated you to become a CRNA, since you're our youngest members here.
Sure. So I think that some of the CRNAs kind of touched upon it already. Just the ability to take what you've learned as a nurse already and maybe elevate your practice a bit. The wide variety of settings that you could practice in, whether it be an acute care hospital or an outpatient setting. The challenging cases that you see, just the mental stimulation, the work-life balance, financial stability, those are all reasons that I strongly considered when I was looking at going back to school.
For me, since I had been working for about 3.5 years, I just found myself being really drawn to really acute patients and the type of care that they required. And I also found myself wanting to do like something a little bit more than being at the bedside. So that's what motivated me to go back to school.
Did you consider other options besides
No, so
anesthesia?
when I went back to get my accelerated BSN, I kind of had already been drawn to the anesthesia line of work, so there's really no other considerations. I actually worked with, at a plastic surgeon's office after my first degree, and he had a CRNA that would come into the office to administer anesthesia, and I was talking with him about it, and the more that I learned about his job, the more interested I became in everything, and that's kind of what was the impetus that got me looking in this direction.
I did at a point during my while I was working I was thinking about doing NP, but once I had shadowed a CRNA and like had seen what they had done, and also worked with NPs on the unit, I definitely decided that I wanted to do anesthesia. So it was the shadowing part for me that kind of helped me decide.
Okay, this next question is for all of you. If you could explain to our audience a little bit about the ICU experience that you think is most helpful in preparing you for anesthesia school. Start here.
I think pediatric ICU. I don't think there's one specific ICU that is better than the others. I know kind of historically they say maybe the CTICU. I personally got experience my pediatric ICU. I got transplant, fresh transplants, I got neuro, I got some cardiac overflow, I took care of neonates. It was more of a well-rounded experience to me. I think it's just really dedicating yourself to your job and learning everything you can while you're there. I don't know if everyone agrees, but I don't think there's one that's better than the others.
I would agree with that. You know, I did neuro and trauma. That's my ICU background, but I would say just the experience of being a nurse. You know, I don't know how many of you are just planning on going to nursing school, aren't nurses, but that first year of reality shock that they talk about, being a nurse, that's legit. And so you need to learn how to be a nurse. And then that second year, you need to learn how to talk to doctors and how to stand up for your patient, because that's what you're going to be doing in the OR. You're going to be telling the surgeon, hey, stop, something's wrong. So you need to be able to advocate for your patient and just have that voice. So I really think at least 2 years of experience is, in my personal opinion, is a good thing to have.
Yeah, and I wouldn't say there's one that's better than the other either. We have people in our program that are from the medical ICU, surgical ICU. I'm a little bit biased to the CT ICU since that's where I've worked for the past 3 years. You'll see all kinds of types of things going on in the CT ICU, and just because you're only dealing with hearts doesn't mean you're not going to be dealing with neuro patients, because there's lots of stroke issues with that going on. So you'll get a whole wide range of experience. But what I would just recommend is maybe trying to work in a pretty acute unit if you can, in a larger hospital. That'll get you exposure to more cases than if you were in like more of a community setting, because generally if you have a sick patient there, they'll try to stabilize them and then send them off to a tertiary center.
Yeah, I think it's important not only to, I don't think the experience or the type of critical care situation you're in matters as much as being a good ICU nurse. I think a lot of people, unfortunately, go into the nursing aspect knowing they want to get into anesthesia, and they're treated as just a time. They had to spend this many years here and then they're moving on. Now, learn what you're doing, learn the drips you're hanging, why you're hanging them, that kind of stuff. Be a good ICU nurse and understand why you're doing these things for your patients. And when you go into anesthesia school, you're going to realize that helps a lot.
I can't say it better than that.
I do agree with them. I took a couple more steps when I was in the ICU. I precepted new nurses, and I also was in charge, and I think growing yourself in the unit too that you're working in a little bit in ways that you can also helps you develop your nursing career and your profile as a professional healthcare provider.
So some of you out there might be wondering what kind of experiences are not accepted in nurse anesthesia programs. So the Council on Accreditation of our anesthesia programs, our national organization, requires all applicants to have 1 year of critical care experience. Our particular program at Pitt believes that that critical care experience should be ideally a good ICU with ICU type of experience, but it can be a emergency department that's part of a level 1 trauma center where you're doing critical care patients on a regular basis. Same with the PACU that is also taking care of maybe post-op cardiac cases, and so there's some of that experience can actually be some very good experiences, but a little bit more on an individual plan looking at it that way. Neonatal ICU generally has not been one of the accepted here at Pitt. A regular PACU experience. What are some of the other examples that people ask about?
I know
ER.
certain schools don't accept PICU, but I think if it's a large PICU, you get a lot of experience like at a standalone children's hospital. I understand like community pediatric ICUs have like maybe 6 beds, and then turf there, as Shane said, turf their sickest patients to tertiary care. So I know there are some schools that do not accept PICU.
Truck driving school, that's not acceptable.
EDOR nurses.
Right, operating room nurses is not considered a critical. I mean, it's at some level it's critical, especially in a place like Presby or Children's. It can be, but it's the hands-on management of a patient and the equipment, the monitoring equipment, and management of infusions and drips are what makes it that the operating room nurses don't have that type of experience. Want to do the next one?
I can do it. For all of you, what should you do if you can't immediately get into an ICU after graduating from nursing school? Do you have any recommendations?
I didn't get into an ICU right off the bat, and I think it really helped me. I did a year in a medical surgical floor where I had 7 to 8 patients, and that really helped me develop my organizational skills and everything like that, introduced me to the nursing field, and after a year there, I moved on to the ICU, and I already had that experience with managing a bunch of patients and everything like that, so that made my transition a lot easier. I don't think it's an absolute necessity that you guys get into the ICU right off the bat, but I wouldn't fear going into the ICU right off the bat either. I do think my time did help me a lot with that transition though.
I think that actually not getting into the ICU right away may actually be helpful, because that's one more experience, that's one more knowledge base in your toolkit. You know, when I graduated in nursing school, I went into chronic hemodialysis, which is as far from critical care as you can get, by the way. But that still taught me a lot. That gave me one more piece of the puzzle in nursing, and helped me with my organization, and helped me with drawing up meds, and all that little stuff that you need to learn to make you a better practitioner. I think if you don't get into nursing school, or a critical care unit right away, it doesn't matter. You need to be a nurse first. Learn everything you can, and while you're doing that, go take your ACLS classes, go take your PALS, go get all of that stuff, increase your knowledge base, so then when you start putting things on paper, you know, you're going to be able to compete against people in anesthesia schools and say, well, I have 2 years of CTICU experience. Well, great, I have a 1.5 year CTICU experience, but I have a year of chronic hemodialysis, I have my ACLS, my BCLS, my PALS, blah, 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 blah. It's going to make you look a little better.
Anyone else have any Any thoughts on that?
Just to echo that, I didn't get into the ICU right away either, and I think it helped me develop as a nurse overall as well. Just continue learning, reading, never stop that. You'll be fine. So, of course, if you can't get into the ICU, if that's all you want to do, that's perfectly fine too. It all depends on your financial situation. If you can wait for that perfect job to roll along, but if not, there's nothing wrong with taking a first job outside of the ICU.
I think there are some ICUs as well that would prefer you to have a little bit of experience before they hire. Some ICUs do not want to hire brand new nursing graduates into their intensive care units.
When I graduated nursing school, you couldn't get a job in ICU right away. Nobody was hiring.
Yeah, I agree. That was my experience as well.
Yeah.
When I graduated, that's all that was available. Was ICU. You could get into any ICU that you wanted. But that was when I was 10, so maybe I was.
Yeah.
Can you, some of you like to offer the difference of being a graduate student versus undergrad?
Well, I will say you do have to learn a lot more information at one time than I remember in undergrad. It's been a little while, but I do find myself a little bit more organized and keeping on top of things more than I did in undergrad.
So you're more mature.
I am. Yes, I am.
And there's a lot more work.
There is more work. There's one of our professors called it a learning curve, but there's a lot more material that you have to cover in almost a shorter time period. I haven't had a whole lot of the anesthesia classes yet, but just the graduate level classes I did notice there's a lot more information.
Not only that, but there's other stressors involved that might not have been present in undergrad, financial stressors, family stressors. You just need to be ready to deal with that. But at the same time, you need to find a good balance between school and personal life. Don't dive straight into the books head on and that's all you do, because you're going to burn yourself out. So you need to find a way to kind of relieve some stress and find a healthy outlet for that if need be.
I would also say clinical is much more intense in anesthesia school. I mean, those early mornings, like nursing school was tough, don't get me wrong, but anesthesia is a whole different beast.
And I think anesthesia school was a little challenge. It's like kind of a culture shock, because in nursing school, I feel like I didn't know what was going on. And then I became a nurse, and that first year was, as Holly said, was rough. And then you become one of the top people on your unit. People are coming to you for help. You're organized, you're confident in your skills. Then you get into anesthesia school and everything seems like perfect. And then you start clinical and you can't even spike an IV bag anymore. And your confidence is just so low. So not only tougher classes and feel it's more responsibility in your learning, you have to be really on top of your studies to make sure you're learning the content. You also kind of have a humbling experience where everyone knows you're brand new and you're learning, but it's kind of humbling for you. So you kind of have to deal with that as well, to know that you're at the bottom learning again.
Well, John alluded a little bit to the next question, but are there any personal or professional challenges that come up during anesthesia school that you have any suggestions for management?
Well, we haven't started our clinical yet. Here in the DNP program, we start clinical in November, so I'll be looking forward to those challenges. but I'm excited to start it. I'll be at Presby taking care of some of those trauma patients with John, hopefully. Like I said, I think a lot of the students that you'll run into in an anesthesia type program are the type A personalities, so you need to be ready for that kind of challenge too, to deal with your classmates. A lot of times in nursing school it's all friendly and stuff, but here it can be competitive at times, so don't take that the wrong way. Just know that's how a lot of people in the school tend to be. And like I said, try to find a way to deal with stress. I know a bunch of my classmates and we go out golfing almost weekly, and just to decompress while the weather's nice. The 2 weeks out of the year here in Pittsburgh. So that's about all I have to offer so far.
I would say let your significant other, if you have one, know, hey, this is going to be a tough, little period in our lives. I need you there to support me. My husband and I never fought until the worst summer semester of anesthesia school, and he's a physician. He went through medical school, went through residency and fellowship, and we fought because he didn't understand that I had a test every week and I could not you know, go out and have fun, but we fought over cleaning. And it was to the point where I was like, hey, we need to get somebody to clean our apartment because I just can't do it right now. Like, that's just not possible at the moment. So, I mean, just sacrifices here and there, and then take them on a nice trip when you're done.
After you pass board.
After you pass boards.
I was single in anesthesia school, so I lived by myself. So I made it a habit to do 1 day a week or like an evening a week and say, no anesthesia work. I'm gonna like get my life back in order. Say hi to my family. My family refers to my 28 months in anesthesia school as the lost years. But I would designate a night where I was gonna take a break from the books, not like cram over Typhon or whatever I had to do, and just kind of get my apartment and my life in order, because you can't, I think John said it earlier, you need a balance. You can't neglect your life for that long, and you need to see your family members, and talking to them does help you get through it and kind of keep you sane. You get sucked out of that world that's like anesthesia 24/7.
For the CRNAs, tell us how you work with student anesthetists, and give maybe an example of what you expect or some examples of some experiences.
It kind of depends on the level. So I was actually telling John and Alex here that they're going to be coming to Presby in November, and you know, our expectations are very, very low. And because they don't know anything, they're there to get procedures. I mean, they don't. They're walking into this huge environment, and they've never given anesthesia before. They've intubated dummies. And so you treat them very, very differently. I tell them, embrace your stupidity, because there's nothing right now that you know that, so we have no expectations. We're gonna make sure, we're gonna read you around with kid gloves like you're a toddler, and we're gonna say, okay, I want you to do this, I want you to do this, and I want you to do this, and they're happy to do it. And as we go along, this is why you did this, and this, and this. Now, someone that's been in the program for how long is the program now?
36 months.
3 years, 36 months. So if you're in your 34th month and I'm saying you have to do this, 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 and this, then that's a problem. At that point, when they're seniors, I give them all the rope in the world to hang themselves. As long as they're not going to hurt the patient, I want them to make the mistakes under supervision. I want them to be able to take independent practice. I want them to say, okay, I want to do this, this, and this. And even if it's not the best way, I'm going to let them do it, and then they're going to figure it out. Well, what could we have done different? Okay, so it's it's a whole learning process. So the very beginning, yeah, you're going to lead them by the hand. And at the end, let them spread their wings a little bit.
I get the students later on. You don't come to Children's until you've been in clinical for a year. So actually, I think just 8 months now. But so I get you a little later on, because you gotta get your feet wet and get through toddler stage with John before you come see Children's. But we also, we treat you with kid gloves in the beginning at first too, because most people have never taken care of children as nurses, let alone given them anesthesia. So we kind of self-guide you and kind of give you a little bit more steps, but you spend 3 months at Children's, and by the end of the 3rd month, I, like John, give them enough room to hang themselves as long as they won't harm the patient. I let them do what they want. I, kind of guide them if they need it, but you kind of have that same mini progression over 36 months and 3 months at Children's, but you get all the whole wide variety. As long as you come prepared, I'm happy.
Yeah, preparation's the big thing.
Yeah.
You just come prepared, know your patients. At Presby, they're probably not going to be the same patients you looked up the night before. It's going to be something totally different, and that's okay. Just as long as you're prepared and you're trying. We don't want somebody who just doesn't care and it's like, well, I just didn't want to look it up. That's not going to fly. So just work hard.
Okay, for the CRNAs, while you were in the program, what were your strategies for success? We touched a little bit about challenges and things like that, but did you have any strategies that helped you to prepare academically? Anything that you care to mention?
I think one of the biggest things is you definitely have to start studying well before you start studying in nursing school. It's not a day before cram session, it's like a week before, all week long. You gotta give yourself some time every night to look over things, but don't burn yourself out either. Give yourself 3 hours to start studying, study for those 3 hours, and then move on with your life. Or else you're just gonna get burned out really quickly, and you gotta do that for now 3 years, but you do have to put the time in, I gotta say that.
I would also say I feel like when I was in nursing school, a lot of my studying was memorization. I could memorize whatever bones and things I needed and medication steps. But in anesthesia school, you really have to understand what you're doing and the reasoning behind it and what's going on. So you have to study with the goal of understanding and being able to explain why things happen and things like that. So just learning how to study and for that function versus memorization was kind of a hurdle.
Also for the CRNAs, what simulations helped you as a student, and did they compare to a real life event?
The one for sure that I thought translated really well was the fiber optic, because that's not a skill you get to do too much. When you go to children's is when you get to do it, and I feel like just getting used to the controls of the fiber optic helps so much in simulation, and they make you just do it so often that it's muscle memory that when you go to do it in a real child, it came to me like nothing. Now there are some differences. Dummy's not wet and the mucus doesn't cloud up the scope and stuff like that, but the actual joystick and knowing what you're doing and making it look like you know what you're doing, to have the doctor get off your back for a little bit really did help.
I would say mock induction. I mean, before you even start clinical, John and the rest of the team, they make you go through a pretty challenging, like, just mock induction. You just go through all the steps they want you to get. I don't even remember how many steps it is that you have to remember. Yeah, you have to memorize. But it just prepares you, because that first day in the OR, you're going to be terrified and you're going to do this on a real patient, but you've done this in a controlled setting. You know what steps to take, what, like, you know, steps with your flow of things. So that was just really helpful.
Oh yeah, I agree with Holly. I think mock induction was easily my most valuable simulation. I was like a ball of anxiety before clinical because I was learning all these things. I didn't know what it was expected of me. I had only shadowed in the OR. But I mean, by the time you study so much and prepare so much for that mock induction, so you like watch yourself on video and you do it in front of people. And then by the time you get to clinical, it's like muscle memory. You get through an induction and you're like, oh my God, I just did this. You like kind of stand back in shock, and then John's like, put on the vent, breathe for the patient. But it was very helpful and kind of took the stress out of the first day of clinical.
I got nothing. Simulation was in its infancy back then. I think we worked with SimMan once, maybe. So, sorry.
That's okay. That's okay. The next question is for our students, our two students. How did you decide to apply to the DNP program versus some of the remaining master's programs that are out in the country?
So for me, I never really considered any other school besides Pitt. Just the access to the facilities around here, Presby, Children's Hospital, you know, just this area in Oakland has access to all these amazing facilities that you can go and for clinical. I know some of the other schools that I was researching online, you could get sent to a different state for clinical. So to have the opportunity to have these, McGee right down the street, Children's over in Lawrenceville, Shadyside, Presby, all within just a few mile radius, that was a big selling point. The simulation that is offered here, I think, is pretty awesome. They just mentioned mock induction. We've heard a lot about that already. So I think like just you know the school itself, it's a great opportunity. It's always ranked among one of the best in the country for nurse anesthesia. Being a Pitt alumni, I already knew where I was going to try to go if I could get in.
Go ahead.
Along with all the things that John mentioned, I kind of saw where the degrees for anesthesia are going, and I know they're all going to have to be DNP at a certain point. So I knew that this is what I want to do, and I've just figured I would get it all done while I'm getting my anesthesia degree, and that in the future could open other doors for me if I wanted to teach, if I want to do more research. I already have the degree, so I don't really have to go back.
It's fun going back to school. For anybody who would like to answer this question, how can a potential applicant get a chance to shadow? I know somebody talked about shadowing. I don't know if any of you have had an opportunity to do that or want to know anything about that, but if you have any information on that.
So, if you want to shadow at Presby, you're going to hold Dale Fleck. He's the assistant CRNA director, and he sets that stuff up. You write it down? All right, hang on a second, and I'll give you his number. 412-647-4975. or you can call the secretary at 412-647-5909. 647-5909. I know that UPMC has a couple of requirements. You have to fill out the form, there's a HIPAA form involved, and you have to have a TB test. But other than that, we take, I just had a 16-year-old the other day. So high school students, college students, they're very progressive because, let's face it, you're the future of our profession. So why wouldn't we want you to come shadow and then to become, nurse anesthetist? We need you. I'm not going to do this the rest of my life.
Children's is the same way. You can call the anesthesia department. I think the secretary's number is 412-692-5260. Or you can just call the main children's number and ask the operator for the anesthesia department. It'll transfer you to Susie and she sets up our shadowing. I believe there's just some paperwork to fill out, the same thing, so you don't need your TB test for children's. But high school is, I think we had a high school student as well shadow recently, but you can come. Sue Kelly is our assistant director and she usually sets it up, but Susie will get you in touch with whoever you need to be. You just fill out the paperwork and come hang out.
And we highly recommend that you shadow before you apply. It's something that's really great to do, to find out if this is something that you're really interested in. It's a great experience. And if you can shadow different places even for comparison, it's very valuable, I think.
So also when I was a BSN student at Pitt, I think during your sophomore year, you go into the OR for the first time just to see what it's like. And one of the nurse anesthetists at Presby was like, come look at my corner and see what I do here. And I kind of was hooked. I really liked what was going on back there and I was interested in more. So I talked to my advisor about it, and she told me to talk to Dr. O'Donnell about setting up an independent study. So I had talked to him about it, got in contact with him. I think I interviewed with him. I'm not really sure if I had to or not. But I did an independent study. It was like a 1 or 2 credit class. I could choose what. And I met with Dr. Donald throughout the year or the semester to discuss topics of anesthesia. But I also did, I think, 80 hours of shadowing. He set me up at different sites. I shadowed at Presby and McGee, and they kind of walked me around. I got to see the labor unit and watch everyone put in epidurals. I was in the main OR and at Presby. And then I did like a simulation similar to mock induction as an undergrad student. So it gave me a lot of good exposure to make sure this was something I had wanted to do. So I don't know if that's still a thing. I'm sure
so
it is.
The independent study now is for the students in what's the program?
Honors program?
Honors program.
Oh, okay.
So we still do it, but at a different level. So
okay.
it's not as independent as it used to be. It's now tied in with that. But it still exists in some form.
And I think the last thing is just something that they wanted us to explain about the differences between the master's programs and the DNP and how it's transitioned here at Pitt. So one of the things that we have is a capstone project or a scholarly project. So in order to complete the requirements for the DNP, you have to choose a quality improvement project, something that will make some changes in an operating room setting pertaining to anesthesia. So that's a big focus of academia as well for the DNP. Also, there are classes along the way that help to prepare you for the DNP project or scholarly project. There's database management classes, informatics, a whole series of classes that help to prepare the student to write the whole process of the project. That's one of the things. Bettina, do you have any other?
Other than just the specific list of the courses, comparing when students who graduate from the master's and what we take now in the DNP courses because there's a program for CRNAs to finish or do a DNP completion. So a lot of those courses are part of that project. So a DNP project, as well as taking the informatics, policy, ethics, some of the courses that we didn't have in our master's level program. So we have the extra 2 terms added on from our master's degree program. The progression of the anesthesia curriculum, the clinical curriculum, is very similar. There's not a lot of difference in how we teach the anesthesia, the clinical part of our courses. What is different is some of these additional courses that make up the DNP and helping to work getting through a project.
And the curriculum is structured so that a lot of those courses are in the first 2 terms. Clinical doesn't start until the 3rd term, so for our students here, it would be around November, I believe, that you'll be starting in clinical. So you're able to get the core courses out of the way so that you can focus more on the anesthesia courses when you're in the clinical setting.
So that's the end of our list of questions we have for our panel. If you have any questions from them here from the audience, we'd like to hear them.
So moving from bedside nursing to nurse anesthesia, did you guys find that you lost the nurse-patient relationship to any degree, or do you still feel that you have those good relationships with your patients?
You still have it. You just have a shorter time frame to establish a good one with them. When you go up and do your pre-op, it's important that you establish a good relationship with them because you need them to trust you, that you're going to be taking care of them through the surgery and that you're going to watch them and that you're going to keep them safe and you're going to keep them pain-free and you're going to wake up at the end of the case. So you have a shorter period of time, but you still have to establish that relationship, and you do for the most part.
Yeah, I would just echo that. I think if anything, it gets better. I mean, it is a short amount of time and you're probably never going to see these patients again, but as Shane said, you just have to make this connection in such a short amount of time. You just become, I don't know, you just develop these skills of how to talk to patients even better.
Along with that, you're talking to an immediate family member, usually with them as well sometimes, so you have to consider this whole little. We move from being ICU nurses, and oftentimes our patients are unconscious, they're on ventilators. We don't actually get to communicate and talk with them for long periods of time. We are dealing more with the family. So when you have an anesthetic that you're going to be giving, because a lot of patients are coming in that are basically healthy. They just have maybe a broken bone or having tonsillectomy or whatever. So they're healthy people. So now you have to actually talk to your patient and actually have this different kind of rapport compared with an ICU type of patient. And getting them to trust you in a very quick, short period of time. And at the end, it's nice to see a case from beginning to end, and you feel like you've accomplished something, and it's different than having this long-term kind of take care of this patient day in and day out. They're getting better, they're not getting better. So it's different kinds of rewards and different types of rapport with your patients and families.
I think that's true, and I also think that patient advocacy is much stronger in anesthesia. I mean, you're the one that's in the room with the patient, and so you need to feel comfortable with your communication skills and speaking to the team about your patient if something should arise.
Good question.
So I'm a senior nurse. Share the mic. You won't be able to pick it up if not. Sorry. Thanks. I'll be a senior nursing student in August, and I know that anesthesia is the path that I want to go on. Do you have any advice for things that I could be doing now or after graduation to prepare myself?
Sure. I think that you hone your study skills. They should be pretty good right now if you're a senior and doing well, but continue to hone those. Get a job and learn as much as you can about everything, okay? Really, really become a good nurse. Become that nurse, that the organized, good knowledge-based, clinically competent nurse, whether or not you get into ICU, okay? As we said before, just because you don't get into an ICU right away doesn't mean that that's bad. In fact, I submit it's actually better. But in any place that, any place, facility that you find yourself, any arena of nursing you find yourself, apply yourself, learn as much as you can, continue to build that kit, that toolbox, so that when you do get into anesthesia school, you can rely on that a little bit more, so you're not learning it for the first time. Does that make sense? So just learn as much as you can.
I would also say with that, like, definitely learn as much as you can, and as Shane said, become the best nurse that you can be, but also go and live your life for a few years. Like, go and spend that money, go start saving, but go on some trips, just enjoy your life and enjoy that time, because anesthesia school is intense. It will get so much better when it's done, but just, yeah, you've gone through all this stuff, nursing school, you need a break.
Also, as a senior nursing student, I know Pitt offered GRE practice tests that I used to take. They were free. They offered it for like the entire university, not just the School of Nursing. So I took advantage of those because you have to do like trigonometry and things I hadn't done in nursing school for a long time. So that was very helpful for when it came time to actually studying for the GRE, like after you pass your NCLEX and all that and are getting your application ready. It was very helpful to have that in the background. So take advantage of all the things your school has to offer you.
For the folks in our audience who might be even younger, I will always, as I've told my own kids, you can never change your QPA and your grades. So get the best grades you can while you're in school, especially undergrad, because you can't go back and ever change those QPA and those grades again. So take advantage of really trying to do the best that you can as a student, because that's one of the things that is looked at on our applications or your QPAs as an undergrad student. So keep making good grades. You won't find too many unhappy CRNAs. I think it's one of those professions where there are a lot of people who are just happy, and they're happy with their jobs. It's a very satisfying job. It's very rewarding. It's not easy at all, but it's a lot of fun.
Absolutely.
I think that you will find not too many people disagreeing that it is a fun career. And there are lots of options, just like nursing, where you can be bedside and take care of a patient day in and day out, or you can get into education, you can get into administration, you can do research, you can do a lot of things that you can do in private practice, working in doctor's offices, working in surgery centers, working in level 1 trauma centers. There's a lot of opportunities. Military. More questions?
For those of you that are
hold on, we got to get you a mic.
For those of you that are in the program now, what's your schedule like day to day?
Right now, we only have class 2 days a week, but I do find myself doing work like on the other days, and I still work casually.
How much are you able to work?
I really probably could work 2 days a week right now if I wanted to, but I kind of don't.
And as a fellow casual worker, I
yeah, and then actually during the first semester, we only had class 2 days a week, but I still work casually, and then I also TA'd for the school. So that's like another option you can do for working.
I think that's a little different from what the MSN was compared to the DNP. We really didn't have time to work. I mean, some people did because they're crazy, but you really don't. And
once these students will start the fall term, which is much like what the old MSN 27-month term looked like, it gets more difficult to try to work when you're doing clinical, because you're now almost 5 days a week, 1 or 2 days class, and 3 days clinical, 2 to 3 days, and then it moves to 4 days of clinical. So it makes it much more difficult unless you spend some weekend time.
And on some of those clinical days, you still might have class, and afterwards, like you get to clinical around 5 or 5:30. You're there until 3, and then you come back over here for class for 4 to 6:30 sometimes. It's not every day, but.
Yeah, if we had any of the DNP students who are ready to graduate in December or even next December, not too many of them would tell you they're working or they could work. So I don't know what the actual numbers are. There's always a few that still will continue to do something because they need to for their family, but for the most part, it's very difficult.
Yeah, and like Bettina said, I'm anticipating not working coming up in the fall. So, working with Alex here and there, and trying to get a little bit of spending money in between while I still can. You can TA. I did TA as well. So generally, you go 2 days a week. If you decide to go that route, you get some help with tuition, a stipend, and health insurance. So that's pretty nice to offset some of the cost of school. It's one of the benefits of the program going to DNP. But yeah, the first 2 semesters classes are 2 days a week, all day. So you really can't work those days. And then later on in the fall, we still have class a couple days a week and then clinical. So it'll be pretty much impossible to work, go to school, and study during that time frame. It's a demanding program, but it can be done. There's a couple people in our class that have children, so not sure how they balance everything. I couldn't imagine that, but they get it done, and there's people in the class ahead of us that have children as well, and they make it work, so it's not impossible.
Well, that was definitely one of my questions. I was wondering if anybody in the master's program or the works, continues to work and go to school at the same time. It sounds like.
Yeah, the vast majority have to stop at some point.
Yeah.
So you can try for a little bit, but most people don't.
Yeah, and then once you start clinical,
It's
in
like a
between,
full-time job.
yeah, and in between semesters when you're not in class, like between fall and spring semester, or whatever the summer semesters, you're in clinical 5 days a week. So those weeks that you don't have class, that would be like Christmas break or winter break or whatever, you're in clinical 5 days a week.
The program tries to run the time off more like a job. So we give so many days of vacation days and ill days a year, an academic year, for the students to choose when to take those breaks. So it might not be ideal to take that 5 days between a term, the 2 terms, to be the days off automatically. So those are days where students go to clinical and they can take vacation days at other times of the year. So it's worked out really well to continue in a solid time period when students could be working 4 or 5 days in clinical, really getting some good cases and some organization skills down during that time period, and then taking their 5 days vacation with their family the week later when everybody's together. So it works much better.
That's really good information to know, and John had mentioned about the financial aspect. I mean, I'm in a completely different field from you guys, but I'm used to, you get your undergrad, you're employed, now your employer pays for you to go on. It sounds like here that's no way going to be an option.
No.
So you have to be financially stable too.
Yeah, student loans are always an option. Don't want to take too many of those, as we all know. The Army is another route that you could go if you want someone to pay for it. I know that there's some programs through that where you could do the Army Reserves or active duty, and that requires different lengths, a different contract, but they'll give, I think, up to $200,000 or so. I'm not sure the exact figure, but it's a pretty significant number, and then they'll also give you a stipend and money for books, but you owe them some time after you get your degree. You might just put that time in, or you might stay for longer.
So one other thing then, so most of you here have MS, and then you talk about the DNP, but you're all practicing anesthesiology in MS. Is it moving towards that you have to have a DNP now?
The National Association has said all anesthesia programs have to be at the doctoral level. They could be Doctor of Nursing Practice or Doctor of Nurse Anesthesia Practice. So they're not all nursing, programs don't all sit in nursing schools. They sit in allied health programs, so they have different degree letters after their names. And that is by 2025. So we were eager to make sure that we were well established and in place before that deadline. That's way too late.
It was just like the push from associate nurse to BSN. They wanted everybody to have a BSN. Obviously, there's plenty of people, practicing nurses out there who still only have an associate's degree, but they want everybody from here on out to have a BSN.
And it's valuable for our role because the level of expertise that we hold, we have, when you see occupational therapists and dental hygienists and opticians, they're all doctoral level degrees. We should have been there really much earlier than we are now, but we're doing it now.
Are you called doctor?
Not the masters, that's for sure.
Those of you who are going to be DNPs, are you doctor?
I wouldn't. I'm not sure. I wouldn't. I'm not sure if I'd use the official title or not. I'd rather just be called a nurse.
I think maybe the first day I graduate, I'm gonna make everybody call me doctor.
Do you think you get more respect from the physicians that you work with since you have a doctorate?
No.
I have seen a few colleagues who will go up to patients and introduce themselves as Dr. So-and-so, but half the time the patients don't even know what a nurse anesthetist is. So, yeah.
Plus, I think our surgeons, I think the nurse anesthesia field is very well respected through all the surgeons.
Absolutely.
I don't think us needing having a doctorate degree would change my level of expertise in their eyes.
You mentioned a distinction between a DNP and a DNAP, or a DNP that practices anesthesia versus a DNAP. Can you elaborate on that?
They're just different educational programs. The anesthesia practice is going to be the same. They just are sitting in different colleges. So instead of sitting in a nursing school, they'll not be sitting in allied health or some other type of program. It just is the education part of it that's different, not the anesthesia practice. There was one other, keep asking. Was there another question? Somebody had another question I thought I saw. Oh, there.
John, my name is Derek Schmack. I have a question regarding your time in the reserves, two parts. So if you could just detail what your commitment of non-active duty is and some of the activities you do, like I think it's a weekend requirement a month, and then if you could detail the activities that you do on your overseas requirements.
Okay, so anytime you get an Army commission, as soon as you sign the dotted line, you have an 8-year commitment. That's by federal law. Now, how you serve that, that's where your contractual obligations come in. So I took the stipend when I was in school. It's called the STRAP program, and they gave me a stipend. And so every year that I took money, I owed them 2 years of reserve time. So when I was done, I owed them 6 years of reserve time. So after that 6 years of active reserve time, I could have gone inactive reserve, which means they basically called you up if the Russians were driving down Forbes Avenue. And then after that 8 years, I could have been done. I would resign my commission and be done. As far as what I do now on a monthly basis on my my drill time, I go down to a medical battalion in Richmond, Virginia. We save democracy one PowerPoint slide at a time. Every once in a while, once a year, we'll go out into the range and we'll do that fun Army stuff, which is what keeps me going back. So about half the time it's a lot of fun, half the time it's sitting there and doing the mandatory training. Then you have your 2 weeks a year. This year I'm slated to go to an Indian reservation in upstate New York and help with basic health care. So I'm going to be a functioning nurse. I'm going to do blood pressures and primary care, which is fine because I do anesthesia every day, so that's actually fun for me. When I go overseas, I have 2 missions, or when I get mobilized as a reservist, I have 2 missions. If I stay in the country and go to a medical treatment facility as a backfill person, I've done that. I've had 6 mobilizations like that. I just go give anesthesia. That's all I do. I just like I do at Presby, although not as much of it. I take care of 18-year-old soldiers and their dependents and whatnot. I've been to most of the Army bases you can think of in the country I've been to. I just got back from West Point in February, March timeframe, and that was a very small hospital, bread and butter, a lot of fun. When I go overseas, you can have a number of different missions. You can be in a combat support hospital in like a big base like Bagram or Baghdad or Balad. And that's, you have a little more infrastructure, a little more capability, more supplies, things of that nature. It's more, when you're at the bigger hospital, it's more like you're practicing stateside, except you're overseas and you still have all of the safety issues to deal with. You can also go in what's called a forward surgical team, or now they're called FRSTs, forward resuscitative surgical team. And basically, you're a 20-person team, bunch of dudes, and I include the ladies in that as well. We're all a bunch of dudes. And everything's split down the middle. You have a team of 10 and a team of 10, and usually you're working together. And you do primarily damage control surgery. If they can't survive the hour-long flight or drive to the combat support hospital, they come to you, you do damage control surgery, you stop the bleeding, and you send them on their way. There's no holding capability. So literally you operate and then you put them on a helicopter, and usually either you or the other CRNA will go with them because they're so critically ill. And then remember I said there's team A, team B, you broke up into teams. If a combatant commander is going to do an offensive operation, he feels he's going to take some serious casualties, he'll ask our boss to send one of those teams with him. And so at that point, we'll actually take half of our stuff, we'll get in the Jeep or the Humvee or the helicopter with him, take our stuff, and we'll set up a surgical theater right there with him. So as he's directing the battle, they'll come right to us and we'll do damage control surgery right there, and they get him on a helicopter to get him out of Dodge. And that's it.
Great. Thank you.
Yeah, you're welcome.
One other thing I'll say about money, for those of you who are already at the level of wanting to take courses ahead of time that are in our curriculum, the curriculum is set up to be each term of full-time curriculum courses, so every term is considered full-time, so that's best economical when you're paying for tuition full-time. If you take courses early, you can lighten your load while you're in anesthesia school. So that's a desirable thing a lot of people think about. The only thing we like to caution people and be careful about taking courses ahead of time is that it might make you not be full-time student in one of the terms that you've taken that course. So you have to be a little careful if you're depending on the scholarship, the monies coming in from somewhere, and sometimes it's military, you need to be full-time each term. So some of our students who didn't realize that are caught taking with another course or taking up more credits or something in order to continue with that, so it kind of hurts you at the end. So just to be aware of that, if you're at that level trying to take courses ahead of time thinking, oh, I'm going to lighten my load later.
And if I could add one caveat to that, for anybody that's thinking of joining the military, in order to pay for school, if the finances are your only motivation for joining, don't. You're going to be a horrible officer. You're going to make everybody around you miserable when you get deployed, and it's going to be the worst 8 years of your life, okay? So if it's just for money, I mean, if you have somewhere in you that you want to serve, or that you have that patriotic urge and you just want to see what it's like, that's great. Take all the money that Uncle Sam will give you, because it's great. The money's there. But if, I'm really not into this, but the money's good, so I can do it for 8 years. You can't. So just don't do it.
And you probably shouldn't go into anesthesia if that's all you think you're going to get out of anesthesia as well, is the money. It is good, but you'll not be a happy person if that's all you think that you're going to get out of it.
True.
So do you have any advice for the application process and interviews?
I think the application process, I don't know if it was Jacqueline that said the GRE was a little bit tough for me because I hadn't been in school for a couple of years when I took it. So if you can, I think it's good for 5 years. So if you're like up on your skills and test taking and stuff, try and get that done. And I think to practice, because you do have to do an interview if the school offers. I think I looked up questions online or something and kind of practiced. I did that. And also, I'm trying to think what else I did. Also for my application, what was a good add-on was I got my CCRN while I was working in the CTICU.
Yeah, just anything to differentiate yourself from the crowd is good. Your CCRN, a lot of places will actually pay for you to get your CCRN if you work there, so you could take advantage of that. ACLS PALS, BLS is usually required. ACLS and BLS are usually required. If you want, you can get PALS as well. Pitt's interview process was actually like a round robin type of interview, so we kind of just rotated every 10 minutes for an hour between different faculty members. They did a pretty good job welcoming us and making you feel comfortable. Like John O'Donnell will break the ice a little bit and tell you to relax, but that still doesn't make it any less nerve-wracking. It's something that you worked for a long time, and all of a sudden it's right in front of you. So you just want to make sure you ate a full breakfast before you go in an interview. Try not to panic too much. Some schools, they're notorious for being pretty tough when you go interview. I've heard some horror stories, and those do exist, but at least in my experience at Pitt, it wasn't like that, and I was kind of grateful for that.
Yeah, just boost your resume a little bit. Once you get your nursing experience, start volunteering for committees, be on committees, those type of things. Volunteer to be charge nurse, those type of things. They will look at stuff like that.
And be confident. One of our classmates, actually, on her way to her interview the day of, she got a flat tire, drove her car in the snow with a flat tire, was covered in sweat, just panicking, but she just went in there confident and she nailed it. So, yeah.
Okay. So I think that one of the things I'll say about the interview is that you really want to look at our program under a microscope as much as you think we're looking at you. It's really trying to find an ideal match. You want to come to this program because you think it's right for you, but You know, we want to see if you're right for us, but you need to see if it's right for you. So I would look at it inquiring as much about our program as you would any other program, and think about it that way. And the interview process really helps seal that, I think, from those people. They get that feeling of, I want to be here and work with these people. And that's what we try to feel out whenever we do our interview process.
Yeah, and if you apply and at first you don't get in, just keep trying. Apply again. It doesn't mean that you'll never get into school. So there's a lot of people out there that didn't get in on their first try, and they're nurse anesthetists practicing right now. So try not to be discouraged. It's a little disappointing, but don't give up hope if it's your dream.
I think that's a great place to end it. If it's your dream to be a CRNA, keep trying.
How many are accepted into the school each year?
So our class size each year is around 40 right now. So 40 to 45. Thank you so much for being. If you have any other questions you didn't want to ask in front of other people, then don't hesitate to come up and talk to us. And I think there are refreshments.
There are, yes. Is there any more questions? Or
I think we've done them all, unless you have any.
Great. No, I just wanted to say thank you to all of you for volunteering to be here today. I think it was probably pretty beneficial for everyone to get to talk to you. And like Bettina said, if you want to ask any more questions. We also want to thank the Ada chapter of Sigma, who helped sponsor this event, as well as the School of Nursing and the Pitt Alumni Association, who provided a grant for us to have the food and everything tonight as well. So yeah, feel free to chat with anyone. We also have food and beverages out here. And there are front and back pamphlets out on the table for the anesthesia program. So if you have any any questions about that specifically, I think there's contact information on there, but there's also information about coursework and things like that for you. Also, if there's some people who are here who are not in school yet, didn't get their BSN, and you're interested in doing that, we do have some information sheets about applying to Pitt and the nursing program for your BSN as well. So yeah, let's give everyone a round of applause. Thank you so much.